फ्रेंड्स, दिल थाम के बैठिए क्योंकि हमारे फर्स्ट स्पीकर दिल के ही डॉक्टर है. It's a great honor and privilege to introduce our first speaker, Dr. Bhupen Desai. He needs no introduction, but still I have to do the formality. He's a consulting cardiologist at Heartcare Clinic. He's MBBS, MD, DNB, DM. He's a fellow of American College and European Society of Cardiology. He has 27 years of experience in cardiology. He's worked in various hospitals like Holy Family, BSES, Karuna, Vadia, and many more. He's ex-cardiologist at Larsen & Toubro in Bristol. He's ex-senior cardiologist at Cardiac Safety Quintals Research. He's awarded Inspiring Cardiologist by Economic Times in 2019. Today's topic is recent updates in worsening of heart failure. I welcome you, sir.
So, thank you all my brothers and sisters from Borivali Medical Brotherhood for inviting me here. I'm really delighted. Thank you so much, Dr. Chaya, for your kind word of introduction. And she rightly pointed out that it's a matter of hearts. Dil ki baat hai. Heart failure has become now a pandemic. It is no more endemic. Worldwide, all over the world, whether it is Africa, America, Bangladesh, wherever you are, we are seeing increasing numbers of heart failure. And some 10, 20 years back, I think there was hardly any treatment. Patient used to die. And whenever we used to see a patient of, at least when I was a student, when I used to see a patient of heart failure, all of us used to feel very sad. And we always thought, these are all undated death certificates. Someday he will die and we have to fill up the date only. So it was a very depressing scenario. We had one rheumatic heart disease. We did a lot of work in the angioplasty and all those things. Ischemic heart disease was taken care of. Valvular disease, with advancement in the surgery, congenital heart disease were taken care of. The only last frontier for the cardiologists was a big challenge of heart failure. But now with the availability of drugs, things are improving. As you can see from this, can I have my slides? So heart failure has been a big challenge for the cardiologists. But last 10 years, I would say, we have really conquered this problem of heart failure. There are 4 pillars of the heart failure therapy, what we call it fabulous 4. One is beta blocker, which reduces mortality by about 34 to 35%. Then came the ARNI, we all know about it, which significantly reduced mortality by about 20%. Then is a mineralocorticoid receptor antagonist like spironolactone. That reduced mortality by 30%. And then came SGLT2 inhibitor, which also significantly reduced mortality as well as heart failure hospitalization by about 25%. So now we had these 4 pillars of therapy, particularly for the heart failure and reduced ejection fraction. And that really saved the life of patient, reduced hospitalization, and improved quality of life. We can treat cancer, we know, we can give cancer, but what is the quality of their life? They lose their hair, they lose their appetite, they have infections, they have fever, leukocytopenia, thrombocytopenia. But heart failure therapy, these 4 pillars of therapy has not only improved the heart failure, but they have improved their quality of life. They live very like a normal people. Many of these people go to work also after recovering from heart failure. So this heart failure has several stages, as you can see from this. First is the risk factors. We have a diabetes, blood pressure, but we don't have heart failure. We have coronary artery disease. We have some disease, risk factor. Eventually, it becomes baseline heart failure risk. So patient comes to us with some breathing difficulty, some difficulty in lying down, pedal edema and all those things. So we do initial diagnosis and plan out the treatment, mainly in the outpatient department. Sometimes patients are very late. They are unfortunate. They come to the hospital, but we diagnose heart failure and start treating them. But even after treatment, there is always some residual risk left. As you can see in this, the residual risk is there. Patient will go down. We initiate the treatment. We improve the treatment. We up-titrate the treatment. Despite that, a small number of patients will have a worsening of heart failure. You can see this. Despite everything, the patient will worsen. He go back to hospital. He might come to your clinic. You might have to give him more dose of diuretics and Lasix and all those things. And eventually, it is a downward progression. A stage will come when no drugs will work. Patient will be in hospital. He will be in ICU. Maybe they are on ventilator and maybe on the way to exit. So this part we have to stop. We have understood this part. We have started treating them with all 4 pillars of therapy, but then there is a new entity, a specific entity called worsening of heart failure. And that is something which is a big challenge for us. So this worsening, as I was trying to tell you, is a big entity, and we need to identify this. And why we need to identify what is mean by worsening heart failure. As you can see this.
So that's we give you bottom line. Very wrong.
Am I audible or no?
Yeah, but I'm not Tony. Yeah. Yes.
So what do you mean by worsening heart failure? As you can understand, it's a deterioration of signs and symptoms of heart failure. It should occur in a patient with established chronic heart failure. The word is chronic heart failure. A new onset heart failure who has come to your hospital for the first time, you cannot label him as a worsening heart failure. Patient need to be having heart failure for some duration. It has to be a chronic heart failure. Third criteria to satisfy is it should be on a stable background therapy. Your prescribed medication, patient is not taking medication, and then he worsens, that is not labeled as worsening heart failure. So this is a worsening heart failure despite proper background therapy. And that requires urgent escalation of therapy, as you can see from this. Now, this escalation of therapy can be in the hospital. When patients are admitted to hospital, you give intravenous Lasix, you give them dobutamine drips and all those things. Or you might come to emergency department where they refuse to get admitted. So casualty medical officer will give him a shot of Lasix, will observe him for some time, and then he goes home. Or he comes to your clinic where you give either intravenous or orally, you increase the diuretic. And these are the conditions which has to be satisfied to be called as worsening of heart failure. These are not routine heart failures. These are the patients who are already having heart failure. They were on the treatment, despite on good compliance, they worsened, which required escalation of diuretic therapy either in your clinic or in hospital or in ICU or in emergency department, wherever it is. And why we should worry about this worsening of heart failure? What is the impact of heart failure? It's a bad entity. As you can see from here, poor long-term prognosis and quality of life after leaving the hospital. Most of them will get admitted to hospital because of the worsening of symptoms and signs. Over 50% of patients with worsening heart failure even may be readmitted to hospital within a month. Now, this is old data of 2005. Now it is slightly better. But based on this data in 2005, 56% of patients will be back into hospital within 1 month, within 30 days. Within 3 months, 60% patients will be back into hospital. And at the end of 1 year, almost 65% will be readmitted to hospital. And within 2 years, 70% of patients will be readmitted to hospital. So it's a bad entity. It further, puts patient to the second episode of worsening heart failure. One episode of worsening heart failure is not a good condition. You should prevent it. But if he has got it, he's more likely to have second admission. He will have further worsening of heart failure. And most of these patients will have at least 2 more hospitalizations. So each worsening of heart failure condition puts patient on the downhill course, despite the fact you have treated him. So worsening of heart failure needs to be treated very, very aggressively. This definition is also in a little flux, and how to define it. There's a lot of controversy going on it. We'll discuss about it. But what is the evolution of the definition of worsening heart failure? And why we are so worried about it? Because every worsening of heart failure puts patient on the downhill course. The chance of death increases, chance of going back to hospital also increases, his quality of life also deteriorates. So it's not a good condition. And what are the reasons for worsening of heart failure despite good baseline medical therapy? Probably it is because of worsening of his acute coronary syndrome, maybe because of pneumonia, which is very common in our country. Most of us don't take vaccine also. Then it may be because of arrhythmias. Arrhythmias like atrial fibrillation, ventricular arrhythmias are very common, uncontrolled hypertension, worsening kidney function. Whenever you have heart failure, kidney function also starts getting worsening. So worsening heart failure is also associated with worsening renal function. And in half of the patient, you do not find any reason why it has worsened, but it worsens. So definition of worsening of heart failure. Every heart failure is not called worsening of heart failure. So what is the definition? Signs and symptoms of heart failure have deteriorated. It requires intensification of treatment, particularly the diuretic. It occurs in a patient with pre-existing heart failure. The first episode of heart failure is not labeled as worsening heart failure. As you can see this, de novo, the first episode of heart failure is not worsening of heart failure. And patient who is not taking medicine, patient who has a poor compliance is not labeled as a worsening of heart failure. Why patient worsens? Because heart failure is a progressive disease. Despite the fact you give them treatment, it is a progressive disease. So disease progression, congestion, they can worsen the heart failure. And site of care can be, as I told you, either in the hospital or in the emergency department or in your clinic. So this is how it is defined. And there are 4 things. There could be subclinical parameters of worsening of heart failure like this. Patient may not have any major symptoms, but if you see his biomarker like pro-BNP starts rising. If you repeat the echo, heart pumping goes down. So you can make out patient may not have signs and symptoms of it. We do not use much of device in our country, but there are pulmonary artery pressure monitoring devices are there. Through the femoral vein, you can put it into the lung. So it keeps on measuring pulmonary artery pressure. If the pulmonary artery pressure starts rising, you know this patient is going to worsen eventually. What are the clinical things? Worsening signs, symptoms, and severity of congestion increases. Patient will have a pedal edema, patient will have a bilateral basal clefts, he will have hepatomegaly, and decreased exercise capacity. This event of worsening heart failure can occur either diagnosed at hospital or in emergency department or in your clinic. And why it is so important? Because it is an increased risk of re-hospitalization, increased risk of death, and worsening of the quality of life. First is the vulnerable phase. Even after best treatment, when the patient goes home, the first 30 days is called a very, very important phase that is called vulnerable phase. And as I showed you in the data, in the first 30 days, a good number of these patients will come back to hospital. Despite the fact he has received a good treatment, you have given everything well, and he goes home. But the first 30 days are called vulnerable heart failure. So you call your patient after his discharge from hospital every weekly if possible. First 4 weeks are very important because a good number of these patients will be readmitted, as you can see from here. 1 in 4 patients will be re-hospitalized within 30 days of discharge. And 1 in 10 patients of this will die within 1 month of the discharge from hospital. So this is the natural history of a patient who has a worsening of heart failure. As you can see from here, he comes to the emergency department, CMO diagnosis condition, he feels that he was taking proper treatment, but despite the fact he has worsened, so he diagnoses it, admits the patient, starts the treatment, he goes to the ICU, we give intravenous diuretics and all those things. Patient improves, then he is shifted to the ward. We observe him for some time, we mobilize him, we give him treatment, and then we discharge him. And this early post-discharge follow-up, that is the first 30 days are very vulnerable. So you should call patient more frequently. Maybe you can talk to him on phone or something, but keep this patient under your radar in the first 30 days because he is more likely to come back to hospital. And then it goes into the chronic phase. So this is the most important phase, the peri-discharge phase. And that time, we should start some treatment based on this Victoria trial, and I'm going to tell you something about it. And what was the strong heart failure trial? It says that you start all 4 pillars of therapy before patient is discharged. All 4 pillars of therapy in whatever little dose they can tolerate. Beta blocker, ARNI, mineralocorticoid receptor antagonist like spironolactone, and SGLT2 inhibitor like dapagliflozin or empagliflozin. In the peri-discharge phase, start all 4 treatment. That is what strong heart failure trial is. When initially drugs came, we used to start with 1 drug, build up the dose of that 1 drug, then start with second drug, build up the dose of second drug, then start with third drug. It is not like that. Start, if possible, start all 4 pillars of therapy simultaneously in whatever dose a patient can tolerate before he goes home. And even you cannot start it in the peri-discharge phase. In the first follow-up, you start the whatever is missing. So try to give him all 4 pillars of therapy. There was a trial called DAPA heart failure trial. I'm sure all of you must be knowing about it. DAPA heart failure trial is included patients who were on all 4 quadruple therapy. They were all taking all 4 pillars of therapy: beta blocker, ARNI, mineralocorticoid receptor antagonist, and dapagliflozin. Despite the fact all 4 pillars of therapy were there, 17% of these patients, 1 in 7 or 14.3% of patients had a episode, despite the fact they were in 4 pillars of therapy. So despite giving best of treatment, 1 out of 7 patients will demonstrate some signs and symptoms of worsening of heart failure. And this worsening of heart failure will be much higher if you do not give all 4 therapy, as you can see from this chart here. See, this is the blue line. This is the event-free survival. If you have given all 4, that is comprehensive therapy, means ARNI, beta blocker, mineralocorticoid receptor antagonist, SGLT2, everything has been given, then his survival is much better as compared to patients who are only on ACE inhibitor and beta blockers. You can see this. So if you are given to a 55-year-old patient who has come to you with heart failure, and if you are given all 4 therapies, his lifespan will improve by 14.7 years. 14.7 years at the age of 55. But if you do not give all 4 pillars of therapy, if lifespan will be improved by only 6.4 years. So there's a difference of 8.3 years. So try to give all 4 pillars of therapy in whatever dose they can tolerate. So what are the unmet medical need in India? As you can see from here, 8 to 10 million people, that is roughly 1% of Indian population, do suffer from heart failure. So that's a big number. 10 million people is 1 crore people. They are suffering from heart failure. And Indian patients are slightly different. They come to us 10 to 15 years compared to their Western counterpart. Our chance of developing heart failure is at least a decade earlier compared to the Western population. 30% of heart failure patients are re-hospitalized within 1 year for worsening of heart failure. In-hospital mortality in India is about 10 to 31% compared to 4 to 7% in Western countries. Longer duration of hospital stay. In USA, if a patient goes to hospital, he comes out of hospital within 3 days. For us, it is 5 days, 7 days. So longer duration of hospital in India because of too many comorbidities and lower ejection fraction. Patient comes to us very late in India. Then India spends most in South Asia on heart failure with estimated amount of $1,186 million. So 1.1% of total global heart failure spending is done by the Indian patients. So we spend a lot of money. So it is a big economic burden. So you multiply this $1,186 by 89 rupees. I don't know how many billions it comes to. That much money we spend every year for the treatment of heart failure. So we need to prevent worsening of heart failure. 60% of patients with heart failure reduced ejection fraction will die within 5 years of diagnosis. So mortalities are like cancer. A good number of them will die very soon. So let us see two theoretical patients. One is Mr. Ravi. As you can see, this he is a 72-year-old patient. He is symptomatic heart failure with reduced ejection fraction with 2 previous history of worsening events. He was admitted twice. He was diagnosed with heart failure 2 years back. First heart failure hospitalization was 6 months ago and second heart failure hospitalization was recently. So twice he went to hospital, one 6 months back and one very recently. Now, despite the fact he was on optimized background therapy, his NT-proBNP is still high, that is 2,250. And he had atrial fibrillation, he has underlying coronary artery disease, and he has a history of prior myocardial infarction. This sort of patient we all see commonly, regularly we see about it. He was stabilized with IV diuretic when he came to the hospital, and prior to discharge, he was converted into oral diuretic in discharge. Now he is very worried. He says, I thought my heart failure was under control because I'm walking, I'm okay now, I'm fit in the hospital when you are discharging me. But being hospitalized was a very, very scary situation. I was in ICU, I was very scared, and I hope I do not have to go through this again. So how you can do that? That is by giving certain drugs, which we'll discuss about it. The second is a lady, as you can see here, Sharda. She is a 59-year-old, relatively young 59-year-old lady. She has a symptomatic heart failure with reduced ejection fraction with 2 worsening heart failure episodes. She was diagnosed with as a case of heart failure with reduced ejection fraction 8 months back, and she needed 2 hospitalization. Second hospitalization was 3 months back. NT-proBNP is still high. She was on optimum background therapy, and she has also underlying CKD. So she has a side effect. Now you have given beta blockers, you have given ARNI, you have given diuretic. She started complaining of dizziness, giddiness. So since my therapy was changed, I have been so dizzy, it's really affecting my daily life. So these are the patients we see regularly. So how do we treat them? Look at this Ravi's case, which I told you. The typical natural history of this sort of patient is they were initially diagnosed with heart failure. Treatment was started. Despite the fact when you give good treatment, for some reason he will have worsening of heart failure. Maybe he develops pneumonia or atrial fibrillation or something. Then he gets to hospitalize. He gets stabilized. Then you give all sorts of treatment. He settles down. Additional follow-up, he comes to you regularly. And after some time, he will develop some pneumonia or some worsening. And again, back to the same thing. So this is a vicious cycle of heart failure. And as I told you before, in USA, at least 56% of this sort of patient will be readmitted to hospital within 1 year. So what do we do about this sort of patients? We have to optimize therapy before patient is discharged. It's not safe to discharge him on all 4 pillars of therapy. Maybe you can consider something like a 5th pillar of therapy. And what are those? We will discuss about it. So first you have to relieve his congestion when he came to hospital, treat comorbidities. He has, as I told you, he has atrial fibrillation, he has a coronary artery disease. You treat those comorbidities and treat also iron deficiency. Iron deficiencies are very common in heart failure with reduced ejection fraction. So every patient who comes to you, you must always look for serum ferritin level, not the serum iron level, serum ferritin level. If it is less than 100, you have to give him intravenous ferric carboxy maltase. No other iron therapy. No other iron therapy. Only ferric carboxy maltase. No oral iron therapy. Just one injection of ferric carboxy maltase intravenously has to be given before patient goes home. And then you start or initiate or build up the dose of all 4 pillars of therapy, oral GDME, which are known to improve the outcome. So you give him all sorts of therapy, which in whatever dose he can tolerate, and then send him home. What about Sharda? Now she is getting the side effect of the medicines. You have started all 4 pillars of therapy. She is getting hypotension, she is getting giddiness or something. So maybe you will have to stop MRS, or maybe you have to stop ARNI, or maybe if she is getting beta blockers, maybe you have to stop beta blocker. But something you have to stop. But that will put patient at a higher risk of it. So what can we do about it? Look at this Sharda's case. She is getting unacceptable side effect. Either BP is going down or renal function is worsening because of ARNI and MRS, or potassium is going out. She is getting adverse events. She has multiple comorbidities, drug-to-drug interaction, polypharmacy, advanced age, all those things. We have to tailor according to patient's need. That does not mean that you have to give forcibly all 4 pillars of therapy. Whatever she can tolerate, you have to give that much only. Now, one line about pathophysiology of heart failure. There are 4 components we have understood. There is a RAS activation, that is renin, angiotensin, aldosterone activation. Now, that can be blocked by, in all heart failure, you will have this. So, that can be blocked by ACE inhibitor, ARB or ARNI. There is something called neprilysin inhibitor. There will be increase in the natriuretic peptide. These are a good peptide. They can cause vasodilatation. They will improve heart function, but they have a very short half-life. So, they will be metabolized. So, you have to give a drug like ARNI so that metabolism of natriuretic peptide is reduced. So, there will be higher level of natriuretic peptide. So, this is a positive thing. This you have to block. Similarly, there is activation of sympathetic nervous system. There will be a lot of tachycardia. So, you have to block that by giving beta blockers and then SGLT2 inhibitor. You have to inhibit the SGLT2 inhibitor. So, sugar absorption from the kidney is blocked and sugar will be washed out in the urine. They will work more like a diuretics and also causes natriuresis. So, all these 4 pillars we have understood, and we have had the therapy for all these 4 pillars. But there is a 5th thing, and that is called nitric oxide soluble guanylate cyclase system. This we have understood recently, and this system is positive. In heart failure, this system goes down. So, you have to give a drug like vericiguat, which will activate this system, soluble cyclic guanocyclate. So, we will not discuss much about it, but I'll just tell you in one line how we work it. There is, when you have a drug like cyclic guanocyclate, it will be activated by drug vericiguat, and they will create more of this cyclic GMP, that is guanylate monophosphate. These are very helpful for the heart and helpful for the kidney and helpful for the vasculature also. So, when you give a drug like vericiguat, which is available in India, little expensive drug, but that is a drug as of now only approved for the treatment of worsening of heart. This is not approved as of now for the treatment of all heart failure. So, whenever there are episodes of worsening heart failure, you should give a drug like this, and they will work very well, as you can see from here. Whether patient has not been admitted to hospital, but he has received IV diuretic either in your clinic or in emergency department in the past 3 months, vericiguat is better. When you give vericiguat, this sort of patient who required increased dose of diuretic. Patient who were in hospital less than 3 months, they benefit by vericiguat. Patient who were in hospital 3 to 6 months back, like Ravi, they will also benefit by giving vericiguat. So, among patients with worsening heart failure, those closest proximity to their index hospitalizations, so those who are, the benefit will come very well if the patient was in hospital for 1 month before. Benefit will come if patient was there for 3 months also, but maximum benefit will come to the proximal hospitalization. So, sooner the better you start this drug, it's the best thing. And this is a very well tolerated drug. There is hardly any side effects. As you can see from this, adverse side effects are like placebos. Serious adverse side effects are also like placebo. They have some side effect of giddiness and little postural hypotension, but they are not very high, as good as placebo, as you can see from here. Symptomatic hypotension and syncope. And most of the patient will eventually achieve a dose of 10 milligram. The maximum dose given is 10 milligram. You have to start with 2.5 milligram, then go to 5 milligram, and then go to 10 milligram. And most of the patient, in this Victoria trial, 90% of patients were able to tolerate this drug. While in ARNI and other things, 90% of patients will not be able to tolerate full dose of ARNI or beta blockers.
But last 3 minutes.
Luckily, yeah. It's a very safe, it does not cause any kidney problem, does not change creatinine, does not change potassium, so quite a safe drug. Whether patient is on ARNI or not on ARNI, it is beneficial. So, And look at the benefits it has. When you give paradigm heart failure trial, in paradigm heart failure trial, absolute risk reduction was 2.7, while with Victoria it is 4.2. Significant. These are worse patients. These are sicker patients. These are in hospital. But still you get 4.2 absolute risk reduction with vericiguat. So first you try to build up all these 4 pillars of therapy like ARNI, beta blocker, MR and SGLT2. If patient is still worsening, then you can give vericiguat. So there are 3 settings where you can give vericiguat. One is clinical scenario when a patient was experienced decompensation even after giving full therapy. He has gone to a good cardiologist, he has given all 4 pillars of therapy. Patient has been taking it and still he has worsened, you can give vericiguat. Second scenario is when the patient is on a suboptimal therapy, but you cannot build up the therapy because his potassium is high or creatinine is high or he has developed bradycardia or hypotension. You cannot build up the dose of other beta blockers or ARNI or mineralocorticoid receptor antagonists. Maybe there you can give it. There is certain third setting where the patient has come to you, but full dose of 4 pillars were not given. So you build up those 4 doses. At the same time, you can give vericiguat also. So start with 2.5 milligram, wait for 2 weeks. If patient has no symptomatic hypotension or giddiness, make it 5 milligram, wait for 2 weeks, and then make it 10 milligram. Thank you for your kind attention. Thank you so much. If you have any questions, I'll be very happy to answer your
Yes,
questions.
we can take one question. Okay. I like to call upon Dr. Meenal Panchal to do the felicitation.
Thank you so much.
Sir, DAPA given to non-diabetic patients will not reduce blood sugar.
No, it does not cause hypoglycemia.
And
Dapagliflozin has to be given to all heart failure patients, regardless of ejection fraction, regardless of diabetic status. Diabetes or no diabetes, dapagliflozin has to be given. It does not cause hypoglycemia. In fact, the benefit is more in non-diabetic patients.
Thank you, sir.
Thank you. Thank you so much. Thank you.
So, moving further, I